years. Most of us, and really if you think back, you had a somewhat unique sense and somewhat specific sense of your own gender identity. You understood anatomical differences. If you had a sister or brother, a sibling, you started to begin to understand differences between anatomy between girls and boys. And actually for most, if not a majority of gender dysphoric children and teenagers, the onset of cross-gender interests and activity starts in this very young age, the 2 to 4 year old age. It's not like coming right out of the womb of being into cross-gender activities, but it's usually within the first couple of years. There are obvious themes that develop and favorite colors that are maybe a little bit unusual for the biologic sex. By age 5 to 7 years old, there's an understanding of gender constancy and stability, and behaviors outside of gender norms are essentially corrected, and they're corrected in many ways: ridiculed, shamed, bullied, rejection, violence. And these types of gender norms are often corrected by not only parents and caregivers and siblings, but also school peers and including institutional organizations as well. Right around peri-puberty, the period before, during, and afterwards, we often see one of two different types of reactions. For those that often go on to have pervasive adult and teenager gender dysphoria, we see a real heightening of the gender dysphoria symptoms around puberty. For many other kids, however, who are, it's a phase, or it's an exploration, or it's just something they're trying to work out, sometimes puberty can actually help them have a sort of calibration of who they think they are, and gender dysphoria will actually lessen, and they will go on to identify with the gender that matches their biological sex. And this is a real TSN turning point for many patients in our clinic, and many go on to see to require different types of support. By adolescence, most teens have a stable sense of gender. While many teens may experiment with different sexual orientations to address any gender mismatch they feel. The gender dysphoria onset is always funny when somebody leaves after 5 minutes after signing, and I always want to figure out what that means exactly, but I won't pick on that guy. In adolescence, many teens may experiment with different sexual orientations and address any mismatch they may feel. And interestingly enough, the gender dysphoria onset as a teenager has to trigger some other things on our differential diagnosis. One of those being autistic spectrum, as there can be some aspects of sexual development at that time that become confusing for autistic spectrum people, and they can ruminate about what gender they are, what gender means. And the other one is OCD, and in some teenagers, the themes of their OCD and the focus of their OCD can change from, let's say, religion to, let's say, gender, and this can be a source of ambivalence for them. By adulthood, which I'll talk about in just 1 or 2 more slides, the majority of children remit and do not have gender dysphoria, and do not seek gender reassignment surgery, do not seek hormones. But a majority of teens persist and do go on to seek gender reassignment surgery and hormones. And so let's look at that question. And the question becomes, well, if my kid says, you know, my little boy says he's a girl, well, what does that mean? What's the probability of that becoming something that happens as an adult and something that becomes a pervasive aspect of that person's identity? Well, we have some data already, and the data, it looks like there's an extreme difference in the two populations. A minority of children appear to go on to become transgendered adults. Let me say that one more time. Only a minority of children go on to become transgendered adults. A vast majority of adults, and particularly biological males, will go on to be either homosexual or bisexual. Roughly 80% of biological males that are presenting as trans females as children will identify as homosexual or bisexual as adults. That's very different than adolescence. Once you're past puberty, you continue to experience gender dysphoria. A vast majority, 70 to 80%, if not higher, of adolescents will go on to maintain gender dysphoria and seek SRS as sex reassignment surgery. So in the 2 studies I have there, it's 50% and 67%. The highest criteria for being transgender is seeking surgery. So they're capturing really those looking for the most extreme treatment. So there's going to be also another roughly 20% of individuals who are just receiving psychotherapy support and hormonal support as avenues of reconciling their gender dysphoria. So hopefully that was clear that there really is a big difference in the two populations. And we think that the persisters, the ones that go on to maintain gender dysphoria and become transgendered adults, show higher scores on quantitative measures of both cross-gender behavior and gender dysphoria. And they also meet complete criteria for DSM-4 GID. This has not been replicated with DSM-5 criteria yet, and so that's something we need to do. But there almost looks like there would be a dosage effect, and the more of a higher dose of sort of GD you have as a child seems to be predictive for later on adult transgender disorder. And as you've seen, there's been more recent data in the last just two to 4 years that has shown even higher persistent rates in teenagers, and 2 studies were done, one in the United States and one in the Netherlands, and both showed essentially 100% persistence rate of teenagers presenting with gender dysphoria. Thinking about outcomes, the overwhelming majority of adults who have undergone sex reassignment surgery are happy, satisfied, and express little regrets, and this is a part of a study done in Lawrence in 2003. There are, however, some unsatisfactory outcomes with sex reassignment surgeries. Certainly, the surgical techniques have a long way to go, and I think that might be part of why some of the unsatisfactory outcomes are about. But the regret is really associated with the late transition. And the later you decide to transition, unfortunately, the more physically hardwired some of the primary and secondary sex characteristics become. And therefore, you really have more trouble passing as the other gender. And as a result of that, you experience a lot of daily harassment, daily ridicule, daily bullying, and daily judgment. And I think that's probably a big part of why late outcomes are associated with, late transitions are unfortunately unsatisfactory outcomes. So I'm just going to try to go through the DSM-5 criteria. It's a little bit dry, I know, I'm sorry, but for many of you, you probably haven't had a transgendered patient yet, and so you haven't probably looked at the DSM-5 criteria too closely, so I thought I'd just drag you through it just once. That way you can say you did it. Maybe in some exam in the future, you'll be able to pull something out of thin air. The DSM-4 contained the category sexual and gender identity disorders, and this was completely changed in DSM-5 to changed it so there no longer is even the word gender identity disorder is not in DSM-5. It's now become gender dysphoria. And it's been separated into its own category that creates different criteria for children, knowing that there's a different natural history for children versus teenagers. The A criteria for GD in children in DSM-5 is this, first of all, hallmark symptom, marked incongruence between one's experienced and expressed gender and the assigned gender at birth. This has to last for at least 6 months. You have to have at least 6 symptoms on the following list, and one of them has to be the very first one I'm going to talk about. And the very first one is, of course, this hallmark symptom, this strong desire to be the other gender, or insistence in this conviction that he, she actually is the other gender, or an alternative gender different from one's assigned gender. And as you work in our clinic, and if anybody would like to come out and volunteer and see some transgender patients, you start hearing all sorts of variants of what instead of this binary gender model, you start learning about all sorts of variants of that. So 2 through 8 really focus on all sorts of other aspects of what we do and how we express ourselves in our gender expression. And they are everything from how we dress to the types of make-believe role-playing games we play with others, our preference for toys, games, and activities, our choice of peers, our rejection of what would be classically something that if I was a boy I would automatically accept trucks. Typically with transgendered and gender dysphoric kids, the boy would reject the trucks in favor of the Barbies and things that are pink and things like that. And in addition to those 2 really hallmark symptoms are this really dislike of one's sexual anatomy. A lot of the children that I speak to in the clinic really can't even talk about it. It's almost overwhelming to address the fact that they have this body part that they just don't know why they have it, because that doesn't make any sense to them because they're not that gender. And they also have a strong desire to attain the other sort of body parts for the gender that they want to live, the life that they want to live. The B criteria is the same as with most of the disorders in DSMs, which is the distress and impairment areas. What's unique about gender dysphoria as a diagnosis is that the other specifier is specify with or without a disorder of sexual development. And Dr. Wicklow will speak about these a little bit more in detail in just a couple minutes. The DSM-5 criteria for adolescents and adults includes an A criteria as well, and it's the same marked incongruence between one's experienced and expressed gender. Has to be at least, again, 6 months duration, so it's exactly the same as for children, but you only need 2 of the following symptoms. And you don't need to have A1 necessarily. But again, it's this marked incongruence. It's the strong desire to be rid of your primary sex characteristics and to pursue obtaining sex characteristics of the other gender. A strong desire to be the other gender or an alternative gender. A strong desire to be treated as the other gender, and this might be in many ways, and that's why people seek legal name changes, passport changes, sex designation form, vital statistics forms changes, and things like that. The B criteria for adolescents and adults is, again, the condition has to include distress and impairment. And again, the specifiers for adolescents and adults are, number one, with or without a disorder of sexual development, which we've talked about briefly, and then talking about whether or not this individual is in post-transition. And this is really where you want to speak to whether or not the individual has transitioned to full-time living in the desired gender. And that used to be called the real-life experience, or RLE. And many individuals who were looking for either hormone therapy or surgical therapy had to prove that they were living as the real-life experience of the desired gender. And that was something that was part of the criteria for us being able to write letters. And that's actually since been softened by the WPATH under the standards of care. And now really you can either have either have undergone or is preparing to undergo at least one cross-sex medical procedure or treatment. And this can include merely cross-sex hormone treatment or GRS, which is gender reassignment surgery, confirming the desired gender. Now, there's a list of some of the surgical procedures. Again, Dr. Wicklow will be touching on this stuff in a few minutes.